Good evening. Welcome to the final session of our series, Conversations with Candidates, a joint production of Oregon Physicians for a National Health Program and the City Club of Portland. I'm Ted Kay, City Club's treasurer. Our club has over 100 years of history, producing research and public events to help Portlanders make informed decisions about public policy. You can learn more about City Club and become a member yourself by visiting pdxcityclub.org. City Club maintains a nonpartisan approach to policy. We are faithful to that approach in our participation here. It is beyond argument that the healthcare system in the United States is suboptimal. It costs more, is less accessible, and delivers worse healthcare outcomes than in other industrialized nations. Healthcare is personal to nearly all Oregonians. Congressional candidates' view of our healthcare system is an important consideration for Oregon voters. While City Club of Portland does not endorse specific candidates and has not taken a position on specific healthcare policies, we are pleased to co-sponsor this opportunity for candidates to present their perspectives on healthcare policy to Oregon voters. We thank Susheela Jayapal, candidate for Oregon Congressional District 3, who graciously consented to talk about healthcare policy tonight. Now, it's my pleasure to introduce Betsy Zucker of Oregon Physicians for a National Health Program, our moderator this evening. Betsy?
Thank you, Ted. Good evening, everyone. I am Betsy Zucker. I'm a retired nurse practitioner and a member of Oregon Physicians for National Health Program, PNHP. We advocate for single-payer health care, also known as Medicare for All. Our website address is www.pnhporegon.org. Thank you for joining our speaker series, Conversations with Candidates 2024, in which we offer Oregon candidates for elected office an opportunity to talk healthcare. Before I introduce tonight's speaker, Susheela Jayapal, I'd like to tell you about single payer and why we at PNHP advocate for it. Americans and Oregonians pay twice as much for healthcare as people in other developed nations. Yet our health outcomes are at the bottom of the industrialized world. Americans pay more money, get less care, and cover fewer people than any other nation. We believe any healthcare policy in our state or country should achieve three goals. Everyone can access care when they need it, total costs are lower, and health outcomes are better. The bumper sticker version is better care to more people for less money. Across the world, there are examples of health systems that achieve all three. What all these successful systems have in common are the following. Everyone is included. Everyone enjoys a single comprehensive benefit package, and any patient can see any provider. The most efficient method of doing this is a single payer system, publicly financed, privately delivered, universal health care. However, not everyone agrees with this. To allow you, our audience, to hear different perspectives on this challenge, we invited candidates from major parties who are running for one of Oregon's contested congressional districts to explain how they think about healthcare and what policies they endorse. Please note that a candidate's appearance in our series does not constitute either their endorsement of single payer or endorsement of any candidate by Oregon PNHP or the City Club of Portland. Tonight, we are honored to have Susheela Jayapal, candidate for Oregon Congressional District 3, sharing her thoughts about healthcare at this evening's session of Conversations with Candidates 2024. After she speaks for about 20 minutes, We will have a Q&A session for the rest of the hour. My role as moderator will be to facilitate the conversation between the candidate and you, the audience. Please feel free to converse with one another using the chat function at the bottom of the screen. To submit questions for the candidate, however, please submit your written question using the Q&A button, not the chat button, both at the bottom of the screen. I will ask as many questions as time permits. Please keep those questions courteous and pertinent. At the end of tonight's session, you'll have the opportunity to answer a questionnaire about your experience tonight. And with that, Susheela, thank you for joining us. The mic is yours.
Thank you so much, Betsy, and thank you to PNHP and City Club of Portland for putting on this series. It's such a valuable opportunity, and of course, thank you for everyone in the audience. Really appreciate your being here and appreciate this chance to talk about this incredibly important subject. So, I'm going to frame up the healthcare conversation with a little bit of context about me and about why I'm running for Congress. About me. I came to the US when I was 16. I'm an immigrant. I was born in India, came to the US when I was 16 to go to college. My parents really believed in the American dream. And that is a phrase that some of us have become cynical about, but like millions of people around the world, they genuinely believed that in order to give me and then my sister a fair shot opportunity, they needed to send me here. They did not have a lot of money. They really wiped out all of their savings to send us here. And the sacrifice they made wasn't only financial, it was also personal, which is that they have never moved here. They did not come here with me. So they're still in India. They are now 84 and 94 years old. And they're growing old. They have significant health issues. They're growing old without us. That sacrifice that they made is what I carry with me every day. I still remember my first day on campus. I remember standing on the railroad tracks, everything I owned in a suitcase. I don't think I knew where Portland, Oregon was. I don't think I could ever have dreamed that I would one day be able to try to serve my community in this way. But my parents' sacrifice is really what has driven me, and the recognition that that sacrifice opened doors for me, doors that are shut to far too many people who look like me, who come from other countries, who are immigrants here, who are women, women of color. And that recognition of sacrifice, of the opportunity they gave me, and of the barriers that are in the face of too many people is really what has driven me throughout my career. A little bit about my professional experience. I'm a lawyer, so I came here to college. I went to law school. I practiced law first as a litigator and then as the general counsel at Adidas America. And then some time ago, I really pivoted away from the law, again, driven by the memory of that sacrifice. I focused on public service. I called myself a professional volunteer. I know many of you feel the same. I served on the boards of a number of different nonprofit organizations here in Portland, including our local Planned Parenthood, organizations that focus on education, social services, some of the arts, just a whole range of issues. And in that process, really became, distraught is probably the right word, by what I was seeing in Portland and in Multnomah County. So this was about 2017, 2018, that looking around and seeing how many people were simply unable to survive, much less thrive. And it's hard to remember now, but that was a good economic time, right? 2017, 2018, Portland was on the front page of the New York Times for our restaurants and our lifestyle. And that rising tide was not lifting all boats. It was sinking far too many boats. That, in large part, was what drove me to run for the Multnomah County Commission in 2018. That, and frankly, also the election of Donald Trump a couple of years before, which I think sharpened all of our understanding of what it means not to be represented in government. So ran for the Multnomah County Commission. I served on the commission for 5 years. We went into the pandemic in 2020. And, you know, much of what I thought I would be doing was upended by the fact that we went into the pandemic in 2020. So served through that incredibly challenging time, served through the challenging years that have followed, and in November decided to run for Congress when Congressman Blumenauer decided to step down. A lot of my time at the county commission, and so actually, let me back up for a second and say a couple more things about experiences that have shaped how I think about health and healthcare. First of all, I believe deep to my core that healthcare is a human right, all forms of healthcare. The first kind of healthcare I received as an adult after coming to the United States was reproductive care at my local Planned Parenthood. So it's a bedrock value for me that healthcare is a human right. It's a bedrock value for me that healthcare includes reproductive care in its broadest sense, contraception care, abortion care, IVF or other assisted reproductive technology, so much in the forefront in the headlines right now. It includes gender affirming care. Both my children are at an age where they're thinking about having a family. My daughter is queer, my niece is trans. So these are very personal issues to me, as they are to all Americans. And then at the other end of the age spectrum, it's personal because both of my parents, as I mentioned, have significant medical issues. My father has dementia, my mother has Parkinson's disease. They're in India, where care is cheap relative to the United States, but it's very expensive relative to what they can afford. And if my sister and I weren't able to help them, they would be rationing their care, just like millions of American seniors do. And it breaks my heart that that's what people experience at the end of their lives. And then finally, I'll go back to the county. My views on healthcare are shaped also by my experience at the county. As I mentioned, I started serving just before the pandemic. And what we saw during the pandemic was the enormous underinvestment in our public health system, so that we had to create a barely adequate public health system from scratch when we went to the pandemic. We were not prepared for the pandemic. We were not prepared. We collectively, our health system was not prepared for the multiple crises that we faced, right? Wildfires and pandemic at the same time. So that experience really sharpened. I'm embarrassed to say that when I came to the county, I don't know that I would have put public health at the top of my list, but it sure went to the top of the list as we went through the pandemic. What I also saw was the extent to which our most marginalized communities were absolutely falling through the cracks of that public health system. And I focused a lot of my effort in the early days of the pandemic and throughout on getting care to those communities. And again, it's hard to remember this now, but at the beginning, we didn't have data. And I pushed the Oregon Health Authority for data on who was getting tested so that we would know where the risks were and where we needed to get testing out to. We didn't have communication channels for immigrant communities that didn't subscribe to our state or county Twitter and Facebook feeds. We needed to figure out what those communication channels needed to be. And that was something I spent a lot of time on. And again, that's something that I will carry with me if I'm elected to Congress, the need to understand where our communities live, how they communicate, how they consume information. All of those things were so critical. I published an op-ed with probably colleagues of yours, Dr. Smitha Chadaga and Dr. Alicia Moreland-Capuya, urging the Oregon Health Authority to prioritize communities of color for testing, because we knew that those were the communities that were going to be most affected and that weren't getting access to testing. So really urging that we very explicitly prioritize those communities. And then, as I said, focused on data collection, data disaggregation. At the beginning, the Oregon Health Authority wasn't collecting disaggregated data by race and ethnicity on who was getting tested and vaccinated. So really pushing for that. And then the second piece of the way that, the sort of specific substantive ways in which my county experience has shaped my views on healthcare was also just frontline access to healthcare. As you know, the Multnomah County runs the largest community health clinic system in the state of Oregon. Looking at our county health clinics and the way that we were providing services in those health clinics and the need, again, for language access, for all of the things that marginalized communities need, really had an impact on me. Some of the work that I did was to make sure that our Northeast Portland Health Clinic stayed in operation, and to expand La Clinica, which is a community health clinic in the Cully neighborhood, to create a partnership, really exciting partnership with Portland Community College, where we will be moving into space in their new workforce building on 42nd and Killingsworth. And the magic of that to me is not only expanded space, dental care for the first time, but that we have the opportunity to do wraparound work, connecting with PCC to develop workforce, to provide internships, and also have access to the social services that are going to be in that building, to create a clinic as a community and social service hub, which I think is going to be really exciting. So that's a little bit about me, my experience leading to this point, and then why Congress. Because while local governments do extraordinarily important and often underappreciated and difficult work, solutions at scale, root causes and solutions at scale lie at the federal level, and healthcare, you all know, is a prime example. If we're going to get to single-payer healthcare, and I don't want to bury the lead, I support single-payer healthcare adamantly, vocally. But if we're really going to get to an effective, comprehensive system of universal single-payer healthcare, it does have to be led at the federal level. And that's just one example. Housing, affordable housing, climate change, a huge priority of mine. I think that the county was a leader here, but the solutions at scale, again, sit at the federal level. So housing, shared prosperity, addressing climate change in a way that brings everybody along, that recognizes that it's both a crisis and an opportunity to create good jobs and create shared prosperity and democracy. Protecting our democracy, expanding the right to vote, protecting civil rights, the right to abortion, protecting LGBTQ folks' civil rights. All of those issues sit at the federal level. They're all interrelated. We can't have shared prosperity without a just transition to climate, and we can't have either of those two things without a strong democracy. So that's why I'm running for Congress. Again, really appreciate the chance to be here and to talk with you, and would love to open it up for questions.
Great. We're happy to do that. And I'm going to remind the audience that anything you put in the chat goes to the audience. But if you would like to submit a question to Susheela, you need to use the Q&A button. Just another reminder about that. We've gotten some questions that in some senses you've already answered, Susheela. Namely, do you support Medicare for all? Do you support single-payer healthcare? And I think I heard loud and clear that you do as an ultimate goal for our healthcare system.
I do, and I'll expand on it just a little bit. Given the audience here, I feel like it would be preaching to the choir, and I think, Betsy, you already provided the explanation, the why of single-payer healthcare. But yes, let me just state it very clearly. Again, I believe healthcare is a human right, and I do not believe we should be privatizing the protection and the service of human rights. And that's the system that we have right now. We have outsourced our healthcare. And it has led to the prioritization of profit over people has led to all of the things you described. A healthcare system that is fractured, that's inaccessible, that's enormously costly, and that doesn't deliver the results that we need to see. So I believe the solution is a universal single-payer healthcare system.
Great. There's another question that you mentioned some issues around, but I wonder if you can expand. The question is, how will you emphasize racial and gender justice in a universal care program?
Yeah, I think I sort of gave examples of how I did it at the county level, and I think that's how we need to emphasize racial and gender justice at the federal level, and frankly, whether we continue with the system that we have right now, making incremental progress, or whether we're able to move ourselves to a single payer system. We have to simultaneously think about big strategies and specific ones. And the specific ones I'm talking about are things like communication, education, keeping our eye on the ball that so many of the healthcare outcomes that we're seeing, the ones that the sort of inadequate healthcare outcomes that we're seeing are the result of systemic problems and not individual choices, and that our system has to address those systemic problems. And what I mean by that is, we can have systems that educate people on healthier lifestyle choices, but the problem isn't individual choices. The problem is systems that dictate or preclude certain individual choices. So we can tell people to exercise, but if they live in neighborhoods that don't have parks and that don't have sidewalks and that have dirty air, they're not going to be able to exercise. I won't go through the litany of examples, but I think keeping our eye on those sorts of systemic barriers and coming up with systemic solutions to them is what we have to do in order to address racial justice and gender justice in the same way. Keeping our eye on the systemic barriers that prevent women from accessing the care that they need, whether it's Black moms who aren't getting access to the maternity care, prenatal care that they need, or access to breastfeeding. We need to focus on those systemic issues.
Great. Our next question is, what is the best route for universal health care, national or state by state? And I will expand on that a bit. As you know, Oregon has been developing a governance board to develop a universal healthcare plan here in Oregon. And that's one route. And the other route is obviously national. Would you just talk a little bit about what you think about those two pathways, really possibly in the short run or the long run?
Yeah. I think this is a space where we ultimately need a national universal single payer system. There are other policy spaces in which state by state solutions are good for the long term, but in this case, it seems pretty clear to me that in the long term we need a national solution. Otherwise, we have another fractured system as we have now. It's a different kind of fracturing, but it's still fractured. But in the meantime, as we're working towards that national solution, I absolutely support state by state solutions, state by state single payer systems. I think we've seen states be laboratories for innovation in lots of different spaces. Healthcare is no different. Oregon has been a leader and a laboratory. I forget which state it was, but there was another state that sort of piloted a version of the Affordable Care Act, I think. So yes, I always believe that we need to have a big picture and a big goal in mind, a vision of where we're going, and simultaneously take the incremental steps to get there. I don't think it's an either or approach. I think it's a both and approach. So I'm supportive of states innovating here. I'm supportive, for example, of Representative Ro Khanna's I'm forgetting what he calls it, but basically legislation that would make it easier for states to adopt single payer plans by being able to consolidate all of the federal funding streams into one to create that single payer. And I think that it also creates a waiver of ERISA preemption for employer-funded, self-funded healthcare plans so that we can capture those revenues as well. So very supportive of all of those ways of easing the way to state by state single payer healthcare.
Great. And I think Rokana's bill, people refer to it in these spaces as SABUCA, State-Based Universal Health Care Act.
Thank you. I thought I
Or-
knew there was an acronym and I couldn't remember what it was.
And I've heard Dr. Metz refer to it as the super waiver bill.
Yes. Yeah. That might be easier for me to remember. So thank you.
Mhm. Next question is, how will you protect Medicare and make it sustainable?
So, you know, Medicare is, I think, the best system that we have now. It isn't the same, you know this, it isn't the same as a universal single payer system. My learning and my concerns about Medicare have to do with a few things. First, that it's not comprehensive, that it doesn't include medical, dental, and vision. I think it needs to. I think it also needs to include long-term care. And here I'll come back to my personal experience of having aging parents living in a country where there is not a system of long-term care. And, you know, just recognizing how hard it is for families and for people who need that care. So we need to cover long-term care. We have an aging population. We are all eventually going to need long-term care. It should be covered. The other set of concerns I have to do, again, with privatization, with sort of creeping privatization of Medicare itself. And here I'm thinking of Medicare Advantage, where we know that what's happening is that people are being enticed into those Medicare Advantage plans with some additional coverage, you know, that is provided up at the beginning. But then the providers of those Medicare Advantage plans are overcharging because they are paid more for patients with sicker patients with graver diagnoses. They're upcharging, and we are spending billions of dollars on those overcharges. We know that they are denying care where they shouldn't be. We know that they're delaying care where they shouldn't be. I read a couple of weeks ago a statistic that those companies are making 2 times the profit margin on Medicare Advantage patients than they are on private pay or Affordable Care Act patients. There's a reason for that. I mean, that's not going to care. That's not going to results, right? That's going into their pocket. So very concerned about privatization. And there's another form of privatization, the DCEs. This time I'm remembering the acronym and not the full phrase, but it's basically another way of creating a private system, and it's going to lead to the same issues. So, you know, I think we need to scrap those efforts. That's probably not happening in the short term. In the short term, there needs to be much more oversight. There need to be fraud prosecutions, and I have, there are a number of those underway. We need to expand the benefits in traditional Medicare, I think, so that folks aren't sucked into this private system. And there I go back to, we need to add dental vision. And I'm blanking on dental vision. Someone will remind me. And
hearing.
Thank you. As well as long-term care. So those are some of my thoughts on how we improve Medicare. And then I think there was a piece of the question that was about sustainability. I'll confess that isn't one I've thought of, but what it seems to me is that if we can claw back the profits that are going into the pockets of private insurers for Medicare Advantage or these DCEs, that will go a long way to helping us sustain the Medicare system.
Do you think that there is a possibility of creating a bipartisan support for those kinds of changes to support Medicare in a way that would not require additional funding?
I think there is. You know, I think there's, look, people in blue states and red states are experiencing the same issues here. People in red states are experiencing extraordinarily high pharmaceutical costs, right? People in red states are waiting in line to get an appointment for their colonoscopy. That feels particularly pertinent to me because I spent an hour on the phone trying to get the pre-authorization and trying to get scheduled for a colonoscopy recently. So these aren't partisan problems. And I believe that there are sensible people on both sides of the aisle who can agree that these aren't partisan problems and that we need to find solutions. I mean, I think I think from the good work that you all have done, from the good work that advocates in Congress have done, the conversation is changing. We are far from where we were back when we were talking about the Affordable Care Act. I mean, I kind of vaguely remember how, that's going to be socialized medicine, that's going to be all of that. So I think we've come a long way because the problem is so huge. And I think there can be bipartisan support for things like clawing back fraudulently obtained profits and things like that.
Agree. The next question is a little different direction. Rural hospitals are sometimes going broke. We've seen this in Oregon, sometimes even closing. How can we protect healthcare access for rural patients?
That's a great question, and I will look forward to learning more about it. I will confess to you. What occurs to me as I just sit here and think about it, first of all, I think community health clinics are an enormous resource, and the federal government can invest in community health clinics for rural areas. Again, moving away from a model of private healthcare to a model of publicly funded and financed healthcare. And then I think that all of the other things we're talking about around the rest of the system, or maybe we haven't quite talked about them yet, corporatization, consolidation, I imagine that those issues are part of what's driving rural healthcare facilities out of business. For example, private equity coming in, squeezing profits out, that's going to hit rural hospitals particularly hard. So those are some of the things I think about. I think those are a symptom of the larger problem in our system, exacerbated because of the sort of the geographic isolation, smaller communities, all of those things that create barriers for rural communities.
One of the aspects of many Medicare for All proposals include global budgets for hospitals. And do you see that possibility as one that would support rural hospital systems that are having trouble financially these days?
Can you say more about, or whoever asked the question, about what a global budget for hospitals would mean?
So a global budget would mean that a public system, a public single payer system, would look at the finances to keep a hospital open in a particular area and provide those funds. It would not be reimbursed for each person's hospitalization. Unlike for Medicare for All, people go to a doctor and it's reimbursed from the system. But the hospitals are usually treated differently in most single payer proposals, so that a system can decide that, for example, a rural hospital is providing important services in an area, even if under our current system, they have difficulty with funding, with being profitable enough, whether because they don't see enough patients or whether the mix is more Medicare and Medicaid patients rather than private pay. They may be providing as strong a service to the community, but not being reimbursed.
Yeah. Yeah.
So any thoughts about that as one solution to the problem of rural hospitals?
My immediate reaction is that, yes, that seems very worth considering. And it is a version of acknowledging that costs are different in different places, which I think needs to be done. Frankly, this is an issue with federal funding across lots of substantive areas, that it treats Portland the same as a smaller town or a rural town, and those things can play out in different ways. In some respects, Portland is more expensive, but in other respects, like the one you're describing, a rural hospital with a smaller population base, that is more expensive in the overall budget, of a hospital. So that does make sense to me. My immediate reaction is, and as I said, it's a way of saying one size does not fit all. And our system, whatever system we have, has got to account for the fact that one size does not fit all.
Right. There's some questions that go in a little bit different direction. One is talking about, should we make there's two parts to this. Should we make all healthcare delivery and drug manufacturing nonprofit?
Interesting. I'm going to start with drug manufacturing and say, once again, there is a component to where we are on drug prices that has to do with corporate profiteering, that has to do with pharmaceutical companies being able to control supply. They control supply because they control patents, they control supply. And so whether it should be a nonprofit system or whether it should be a system that takes back to the federal government the ability to regulate, to loosen that supply. For example, if the federal government has contributed to the development of a particular drug, seems to me that the federal government ought to be able to lift the patent or adjust the patent or require that company to make that drug available to other applicants. So I haven't thought about whether the whole system should be nothing but nonprofits, but I think for the federal government to take a much more assertive role on saying what is taxpayer funded is a public good. Similarly, not quite the same as making it a nonprofit system, the federal government we could, as a public matter, be investing more in developing drugs, right? Instead of having outsourced that entirely to private for-profit companies, I'm assuming the federal government can run trials itself and thereby, again, address this question of a stranglehold on supply that is what increases prices of drugs. A stranglehold on supply, and the fact that, when they hold the patents, they're just sort of milking that patent for, I forget what the patent period is, 99 years or whatever it is. So that's what occurs to me on the drug side. And then on the provider side, I think the combination, I really like the way you phrased it, and I'm not going to remember it now, but the combination of a publicly funded single payer system with private provision of care seems to me the combination that's going to work best. And there's always going to be nonprofit providers of care as well, and absolutely should be. But I think that mix is what gets us to an optimal system.
There's another question about prescription drug prices. You may have answered this completely, or you may want to add to it. The question is, how can prescription drug prices, how can we reduce prescription drug prices without eliminating drug research and innovation?
Yeah, I think I came at it from a different angle. But first of all, we can reduce prescription drug prices by actually negotiating for them. And I everything I've read, again, I feel like I'm preaching to the choir and talking to people about things they know much more about than I do, but we can negotiate drug prices, and there's plenty of room in that negotiation to still have a reasonable return on any investment that a company has made in developing those drugs. So that's one piece. And then the other piece is the one that I talked about, which is to actually change the system of drug development and manufacturing such that essentially we're getting a benefit commensurate to what we invest in it, we the taxpayer, whether by lifting patents, whether by saying if we've contributed to the development of the drug, you're going to make it available to others, or whether by doing the development, the research and development within the government. So I think I don't think these concepts are mutually exclusive. I don't think the concept of negotiating drug prices or having a public return for a public investment is by its terms antithetical to drug developers making a reasonable return on their investment.
Right. Next question is, if everyone has access to healthcare that is free at the point of service, won't healthcare costs go up?
I'm going to flip that around and say healthcare costs are really high now, whether it's through premiums, out-of-pocket costs, deductibles, and the overall system cost of this broken, fractured system we have right now, and the overall system cost of so much of what we invest in healthcare going into profit for very large and ever-growing companies. So we already have a very expensive system that we are paying for. It's just not obvious to us, to the individual, what they're paying for. And the system we have now imposes the burden, the bulk of the cost, on the people who can least afford it. So yes, when we switch, I'm going to say when we move to a single payer system, it will be clearer that each of us is paying X in the form of a progressive tax system to fund single payer healthcare. But overall and individually, we'll actually be paying less, because overall it will cost less and it will deliver more.
Right. The next question takes a little bit different angle. It asks if you have spoken with current U.S. Representative Earl Blumenauer about his support of single payer and the barriers he encountered. What would be your strategy for getting results when being bipartisan is often not enough and major victories are extremely rare?
That's a version of a question that I get asked multiple times a day. Well, the two questions I get asked are, why in the world would you want to go to that toxic dysfunctional mosh pit or some variation of that phrase? And how in the world can you hope to accomplish anything? I believe that even in as stuck a Congress as we have now, it is even more important to keep advocating for the things that we believe in. The metaphor I've used is it's tilling the soil, right? We can't let the soil go fallow. We can't just walk away because bipartisanship is so hard or getting a bill moved is so hard. It's important that we keep working at it, because that's the only way we will ever make progress. And I think of accomplishments of the administration has had. I think of the Infrastructure Act. I think of the Inflation Reduction Act. So many of it's not as if they just happened that session. The groundwork was laid over perhaps decades. It's like the groundwork that PNHP has been laying for single payer healthcare. The fact that when you started, it seemed inconceivable didn't mean that you weren't going to try. So I think it's really, really important to keep working at it. And then I think there was a piece of the question that is around bipartisanship, or how do you work together with other members of Congress? And here's where I feel like my county experience has been helpful. We county officials are nonpartisan, and I'm not a we anymore, they deal with really concrete, practical things that affect people's daily lives. And I found that if I was curious, and I am, I'm curious, I'm genuinely interested in what other people are trying to accomplish. So as an example, last summer, I did an exchange with a fellow county commissioner from a rural part of Oregon, Union County. I went to Union County. I spent 4 days there. He showed me around his place that he loves. And then he came here to Multnomah County and I showed him around my place that I love. I'm not sure who was more nervous about it, me to go to Union County or him to come here. But we did, and we found common ground. I mean, we actually found a lot of common ground, and we also, I think, each shifted perceptives that we had of the other's place and misconceptions that we might have had. So it can sound very aspirational, but it's real. And, that we don't have time now, but there were specific, we didn't go with a policy agenda, but there were specific policy agendas, policy items that we made progress on between the two of us. So I think that and I think that that's what Congressman Blumenauer, that's how he's done the work. I think he has looked to find pathways to make progress. And I believe that they exist if we approach it in a really open way. And how can I help the people you serve? And here's how you can help the people I serve.
Right. The next question is, how can we recruit minority students to enter healthcare as a profession?
We can talk to them early. We can remove barriers to education for them early. And I'm talking real, I mean, I'm talking preschool, I'm not saying we're talking to preschoolers about being doctors. I'm saying we're providing a preschool education, and then on from there. We can expand their view of what a profession in healthcare looks like. There's such a range of options, of career options, of work options in healthcare. And I don't know that I certainly didn't know what they all were. I knew doctors and nurses, and I didn't understand the full range of occupations that exists. And we can, when we have candidates who are folks of color, we can hire them, because I don't think there's anything more powerful for a young person than to see someone who looks like them in the profession that they are aspiring to.
Possibly related to that, on almost every measure of medical outcomes in the US, white people do better than Black people. What changes in our healthcare system will address that? And I know you've made some comments about that and even about recruiting healthcare workers, but any additional thoughts?
Yeah, I mean, I think I mentioned several sort of at the top of the hour, and I just first want to appreciate the question. Yes, I think Black adults are, for example, 2 or 3, I forget, maybe 2 times more likely to be uninsured than white folks, and similar discrepancies for Hispanic and AAPI folks. Yes, and at the county, we certainly saw the disparate outcomes across everything, whether it was cardiovascular disease, pulmonary disease, asthma for children, low birth weight. Again, you all know the data way better than I do. To start with, I think that universal single payer health care will go a long way to addressing those disparities. A, because it's universal, and B, because that single payer structure is, again, going to reduce cost and improve access. Recruiting folks of color to the profession, and that's not only to then recruit more folks of color, but because the care that's going to be delivered by people who understand history, culture, trauma, systemic racism is going to be better than the care that's delivered by folks who don't. So those are some of the things I would come back to and reemphasize.
Great. Next question is, should for-profit or private equity companies be allowed to own healthcare delivery systems?
My short answer is no. I think the private equity form of ownership and profit making is sort of a synthesis of everything that's wrong with with for-profit and privatized healthcare, right? It's like a concentrated form of it, because private equity's objective is to come in, acquire an asset, squeeze everything out of it, and then leave. So I cannot conceive of a way to make that work, to deliver accessible, effective, cost-efficient healthcare. What do we do about it? I think is a harder question. Transparency is the first answer. Is we should know when private equity is coming in and acquiring. I think part of the answer is that we need to have teeth and enforcement on antitrust law, for example, and kind of get back into the business of preventing consolidation, essentially, because that is part of what private equity is going to do. Those are a couple of, I mean, the answer, I think the question was just, do I think private equity should become a big player in healthcare? And my answer is no.
This next question is going to be the last one. And it's pretty broad-based. Different countries with single-payer systems have different qualities in those systems. Which qualities are most important to you to be in a US single-payer system?
I wish I could say I was an expert on other countries' single-payer systems, and I am not. So I am not sure I'm going to have a great answer to this question. I'm going to come back to why I believe that universal single-payer healthcare is necessary. So, I think in those words lie everything that I believe is most important, that it is universal, and that it simplifies the whole structure by being a single payer structure, that it is paid for not at the point of service, but through taxation, which, as I understand it, is what the current models of single payer here, Medicare for All, do. So those are the things that I think are most important. But I would love at some point for, if anyone wants to send me reading material, if anyone knows me, they know I love to read stuff and learn stuff. So please send it to me.
Great. Susheela, thank you again for joining us here. We really appreciate you taking this time. Would you like to tell our audience how to reach you or your campaign if they have additional questions or comments for you?
Well, of course I would. But first of all, thank you again for putting this on. Thank you so much, Betsy, for facilitating, and for everyone for the great questions. Yes, you can reach me and the campaign at Susheela at susheelaforcongress.com.
Great. And I am sorry we didn't have time to get to all of those audience questions. For everyone, please visit our website, www.pnhporegon.com, to learn more about Oregon PNHP. You may also view recordings of our past sessions of Conversations with Candidates 2024 on the website, and the recording of this session will also be posted within a few days. And with that, I now turn it back to Ted Kay, our City Club host, to close the evening.
Thank you, Susheela, for sharing your thoughts on healthcare policy. We especially thank our audience for engaging in this important discussion. And finally, we thank our co-sponsor, Oregon PNHP, for arranging this forum. Tomorrow at 5 p.m., City Club will host an online forum with 3 candidates for the 3rd Congressional District. And on Tuesday, April 2nd at 5:30 p.m., we will host an online debate between the two candidates for Multnomah County District Attorney, Mike Schmidt and Nathan Vasquez. I encourage everyone to visit the City Club website at pdxcityclub.org to learn more about us and our events. Membership in City Club is open to everyone. And if you wish, please complete the short questionnaire following tonight's session. Thank you again, Susheela, for joining us, and thank you, our valued audience members, for attending our series, Conversations with Candidates 2024. This brings that series to a close. Everyone stay safe and stay well. Good night.